Well, huge thanks to the NephroCritical Care Society for the invitation to give this morning's webinar, especially with such a fantastic group of researchers and clinicians, leaders that are leading this forum. It's absolutely my pleasure. And look forward to the next 20 to 30 minutes where we'll be able to walk you through a little bit of the nuts and bolts about what goes into producing and interpreting a guideline. Definitely try and have a little bit of spin when it comes to nephro-critical care as well. As mentioned by TAPIS and organizers, my name is Bram Roshwerg. I'm an adult ICU doctor and researcher based at McMaster University in Hamilton, Ontario. Let me just make sure my slides are advancing. In terms of disclosures, nothing financial for sure. And Tapis mentioned some of the other, guideline development projects that I work with. Many societies, the ATS, SCCM, that have helped with guideline development but no financial conflicts of interest to mention. And so in the next 20 or 30 minutes, we'll spend a little bit about time talking about what goes into producing guidelines, how we assess things like certainty of evidence, and we'll use a couple of examples, how one goes from the evidence to then generating recommendations. And I think it's hard, right? Because we get so many different societies produce guidelines that we're left to interpret and understand. And I think it's really important for even folks that aren't involved in guideline development to have an appreciation for what goes into it and how it's done so that they can best apply it at the bedside to their patients, and a little bit of pearls as well. So why grade? Why use a comprehensive guideline development tool? And I'll tell you, folks, this is not the way that it always was, right? For those that know, guidelines maybe 20, 30 years ago, sometimes even more recent than that, guideline development was something that looks like this picture here. And it usually came down to a group of white-haired older men sitting around a table saying, this is the way you should practice because this is the way we've always practiced. And the way we practice, we know is right. And that's the way that everybody should practice, right? And sometimes that's okay, but there's obviously limitations to that approach as well. And I would say that guideline practice, the production of guidelines really changed in the last 20 years. And this was one of the seminal publications that really precipitated that change from the Institute of Medicine. And it talked about main tenets of guideline development that one should always strive to achieve. And these are some of them. A clear conflict of interest management policy. And this is crucial, right? Is that if folks that are in the room producing the guidelines are getting tons of money from industry to push their products, this can be a concern. So a conflict of interest management policy and mitigation policy, a representative panel, the idea of the fact that older white-haired men should be the only ones dictating what care is. Listen, I have a lot of white hairs up there, so I appreciate the fact that, I'm speaking perhaps about a population, including myself, but I think diversity is so important, right? And so having a guideline panel that represents physicians, but also nurses, respiratory therapists, sometimes patients or caregivers with lived experience, different career stages, making sure incorporating young investigators, geographical distribution, and that might be relevant if you're doing Indian guidelines. That might involve having folks from all over India. If you're doing international guidelines, that might involve having folks from all over the world, including the Global South or LMICs too. Coming up with questions ahead of time, as well as outcomes, doing systematic reviews for each of your questions of interest. And we'll talk about this a little bit more, but making sure that you have the best evidence possible to guide recommendations. Rating the certainty of evidence, again, we'll talk about more, thinking about all the factors that should go into a recommendation. The evidence is crucial, but things like resources and costs, patients' values and preferences also really important. Clear articulation of recommendations, and then finally a transparent process. I didn't mention, but I do have the chat open in front of me. So if folks, I think there'll be some time at the end for questions, but if folks do have questions along the way that I could easily address, feel free to put it into the chat. I think I can see it. I'll do my best to address as we go, but certainly time for questions at the end as well. And so, since this Institute of Medicine guidance, GRADE, which I think has gained international recognition, is a framework for producing guidelines that incorporates all of those crucial aspects that I just mentioned. And GRADE now has had uptake for over 200 societies across the world, some of them that are listed here, but certainly, well recognized as a guideline development framework that hits on a lot of these important pieces. So as the next step, I thought maybe we would talk through what goes into producing a recommendation and think about, the sequential steps that proceed from there. And the first step always is to come up with your question. What is the question that we want to answer with this guideline? And for those that are familiar with clinical research, which is probably most on this call, you're probably also familiar with the PICO format. And this is the format we use for clinical practice guidelines, especially around interventions. And we think about what are the specific patients that we want to focus on, what's the intervention, what's the comparison, and what's the outcome. And when I walk guideline panels through this, I often start by sending them like a table and being very explicit on what the PICO components are that we want to think about. Because, you might have a question in your mind, but you haven't properly sort of thought through what the exact PICO pieces are that you want to consider. And so, it's crucial to put the thought into this and make sure that you have a good PICO question. One of the biggest problems with guidelines, those that are on this call that have participated in guidelines are probably aware, is trying to keep scope manageable. There's always an inclination to say, we want this guideline to address everything possible around nephrology and critical care, and there's hundreds of questions that are probably relevant to folks practicing in this field. The problem I've found with doing guidelines, and curious for others on this call that have participated in guidelines, is that if you take on too much, then it affects feasibility, it affects timelines, and the guideline falls apart because it's tried to do too much. And so usually trying to limit scope is a good idea. And these are some of the guidance that I offer panels when you're trying to prioritize which questions to really focus in on. Is it a common clinical question in practice? Is there uncertainty about how to proceed? Timing of renal replacement therapy in critical care is a good one. There's uncertainty about starting dialysis sooner, starting dialysis later. Thankfully, we have new evidence in this field with START-AKI, the ELAINE and AKI trials, a number of them. But there's still some uncertainty in practice of when the ideal time to initiate renal replacement therapy for patients with acute kidney injury. Is there new evidence to consider? And again, I realize START-AKI is now a couple of years old. 3 years old. It's crazy how time goes by so quickly, but certainly maybe incorporating new data into recommendations. And I'll be honest, I don't think I've seen I know Kidoko is working on, I think, updated guidelines, but great guidelines in this area. And maybe there's opportunity if the folks around here, or if the NephroCritical Care Society wanted to take on a guideline development project, maybe there's opportunity here. Is there variation in practice? Important consequences for resource use and cost. Certainly in this case, if we were thinking about this question, there would be. And has it not been previously or sufficiently addressed by other guidelines? So these are the sort of questions that I ask a panel to think about. And, we've really transitioned in the last little while. I would say for folks that keep up with the literature, this idea of like these old guidelines, there were hundreds of PICO questions. I think about the PAD-S guideline. I think about surviving sepsis guideline. We're really moving away from these huge guidelines and more to focused 5 questions, maybe 10 questions. Let's do a really good job. Let's do it quickly so we can get guidance out fast. And then we can move on to, another project that addresses the next 5 or 10 most important questions. And I really think that's the way to go when it comes to guideline development, to pick off, attainable targets and get it done, as opposed to these huge compendiums. Kidoko is another great example. Hundreds of PICO questions, but so challenging to get finished in a timely manner. When we think about outcomes for guidelines, this is important as well, is that we always want to think about outcomes that are most important to patients. And I try to always think about if I was speaking to my brother who's not in medicine, would he think that this outcome was important? And maybe acute kidney injury is a good one. If I'm looking at an intervention that might decrease acute kidney injury, if I were to ask my brother who's not a doctor and not in medicine, hey, if I had an intervention that was able to decrease your creatinine, serum creatinine, is that something that you would want? And I know what my brother's answer would be is, what the heck is a serum creatinine? And I could care less if my serum creatinine's less, right? Is that patients would care about the need for dialysis. Somebody's going to put a line in my neck and they're going to be connected to a machine. These are the sort of things. Am I going to die? What's my quality of life going to be like? And so when we're thinking about outcomes to inform guidelines, we really think about those that aren't important to clinicians, which as a clinician, I would care, can I decrease creatinine? But it's simply a surrogate for the need for some of these more invasive life support modalities. So I think that's important to mention as well. And maybe just lastly on this PICO question generation exercise is that this is so important. And how many times I've been with a guideline panel where, we've moved ahead too quickly without PICO questions that we were happy with. This is probably one of the most crucial steps in guideline development, and it's really important to get it right. Spend the time to get the PICO questions right because the whole guideline development process proceeds from there. And if you have bad PICO questions, it's going to impact the entire process if they're not formulated properly, if they're missing key pieces. And it's not really possible to go back in the end and change the PICO questions because everything's sort of proceeded from there. So crucial to put the time in up front to make sure that you have the questions that you want. Okay, once you've picked your PICO questions of interest, the next step would be to summarize the best evidence for those PICO questions. And we do this using the traditional evidence pyramid, is that there's nothing better than when you're assessing the effects of an intervention, a randomized control trial, and there's nothing better than a randomized control trial than a systematic review and meta-analysis of multiple randomized control trials. Grade dictates that we use the best evidence that you have to address a question of interest. If you have well done RCTs, fantastic. If you have poorly done RCTs, that might be a situation where you might look at the observational data as well. And perhaps, a setting where you have well done observational studies, they might be more informative than poorly done RCTs. If you have no RCTs, you're going to look at observational data sets. If you don't have any observational data sets, you continue down the pyramid, perhaps then to case control studies, case series, animal studies, sort of keep working your way down until you have some evidence, whether it be direct or indirect, that might inform your question of interest. And I've certainly, maybe one of the big misnomers is that you can't do clinical practice guidelines if there's poor evidence on a topic. And it's certainly not the case. We've done very many times clinical practice guidelines in situations where the evidence base is not great. And, we're able to do that by looking at indirect evidence, by moving down the pyramid to expanding our scope to less rigorous research studies, and sometimes even just considering some of the other evidence to decision factors, which we'll talk about soon. Things like cost and values and preferences might still be informative, even in a setting where the evidence is poor. And so this isn't a talk on doing systematic reviews and meta-analysis. Perhaps many on this call have participated in systematic reviews and meta-analysis, but we do tend to do comprehensive reviews for each of these questions. And then you can understand why taking on too many PICO questions could be onerous, because having to do systematic reviews for each can be challenging. One thing it is a lot of work, but we've been able to capitalize on a lot of guideline projects is even publishing the systematic reviews as standalone publications. So, participating in the review, helping with the methodology, not only do you get your name on the final guideline, which tend to be highly cited, but maybe you could capitalize and publish a number of systematic reviews and meta-analysis that come from the same project. One thing to talk a little bit more about is how we decide on the certainty of evidence. And, maybe to drive this home, we'll walk through a bit of an exercise. Always better if this can be interactive, but Zoom is so challenging. I appreciate it. Would have been great if we could have all been meeting in person to go through this, and might have gone a little bit easier, but we'll do our best. Let's imagine a scenario where we're evaluating a new immunomodulator for patients with sepsis, and it's found that this new immunomodulator decreases acute kidney injury. Immunomodulation is the new frontier in sepsis management, using steroids often as our most common immunomodulator, but lots of studies looking at, unique different ones and their effect. And so in this imaginary scenario where we have this new immunomodulator, let's say when we do the meta-analysis, this is our risk ratio that I'm showing here. A 24% reduction. I can say that because the 0.76 risk ratio translates to a 24% reduction in acute kidney injury. And you can see the 95% confidence intervals from 0.65 to 0.89 for reducing acute kidney injury. In this scenario, this is based on 11 randomized control trials, 3,000 patients, well-conducted trials, high number of events. And amongst the 11 RCTs, all 11 RCTs showed benefit of this drug for decreasing acute kidney injury. On a scale of high certainty to low certainty, where would you peg your certainty of this effect on acute kidney injury? I don't know if folks can write in the chat or not. I don't know if I can see it. Again, much easier to do if we could do hands if we were all together. Hopefully, you're looking at this saying that looks pretty good. 11 RCTs, consistent effect, well-conducted trials. I feel pretty good about the effect of that immunomodulator on acute kidney injury, and I'm hoping that's what you're saying in your heads as you're watching me present. Let's go in our brains to an alternate universe where when we did the systematic review looking at this immunomodulator and AKI, we found the same effect, overall effect. You can see, I think you can see my cursor, 0.76, so a 24% reduction in acute kidney injury, and the same 95% confidence intervals. However, in this universe, this was, again, the same point estimate, but based on only 3 randomized control trials, fewer number of patients. These trials were well conducted, but fewer events when it came to acute kidney injury. And not only that, of the 3 randomized control trials, 2 of them showed benefit leading to the pooled risk ratio, but 1 of them showed harm of this new immunomodulator. So a little bit of inconsistency in the effects. And so if we were all together, what I would ask you now is compared to the last scenario where we had 11 RCTs, well-conducted, high number of events, and a consistent effect, now we have fewer RCTs, fewer events, and an inconsistent effect. And if we were to look at this, how certain would you be that this immunomodulator decreased acute kidney injury? The same certainty as the last scenario? Less certain than the last scenario? Hopefully you're thinking in your brains and looking at this and saying, yes, Prashant, thank you for yes. I really appreciate that. Thank you, Kiran. Fantastic. You guys are great. Well, the 2 of you are great experts already, but hopefully many on this call have thought the same thing and felt like less certain in this scenario. Okay, bear with me. One more scenario, one more alternate universe. Looking at the same, thanks, Tanmoy as well. Great. Also a budding expert when it comes to grades. I appreciate that so much. A third scenario, same immunomodulator, decreases acute kidney injury and sepsis, same point estimate, 0.65 to 0.89. So I haven't changed the point estimate or 95% confidence interval at all. Again, 3 randomized control trials. Now, this time, those RCTs were not well done. They had issues with risk of bias. They weren't blinded. There was loss to follow-up, important concerns with the RCTs, a few number of events, inconsistent effects. 2 of the trials showed benefit. 1 of them showed harm. And not only that, but we found actually 2 other protocols where we emailed the authors and they ignored our requests for further data. Again, do we feel like the same amount of certainty as the last case? Less certain in this effect? The same pooled point estimate. I haven't changed the pooled point estimate. But our thoughts on how certain we are in this case compared to the last. I realize asking for engagement. Yes, thanks, Prashant. I appreciate that. That's great. Always hard again on Zoom. Thanks, Shine as well. Certainly. Guys, I can stop now. You're all great experts. And these are intuitive concepts that we're asking folks to apply when we're going through the grade process. And maybe to put into words what you've all just done in your brains is that the certainty of evidence we rate per outcome. That's important, not per study and not per question, but we rate it per outcome. You were just rating the certainty in acute kidney injury, but we would look individually per outcome. And data that comes from randomized control trials starts as high certainty. Data that comes from observational studies starts as low certainty. And then we look at a number of domains, 5 domains, and we rate that there's opportunity to lower the certainty that comes from RCTs, for example, or from observational studies based on issues in any one of these domains. And you went through this in your own brains when you were texting in the webinar chat. If the studies were conducted poorly, i.e. there were issues with risk of bias, you would lower your certainty. If the results aren't consistent, if all the trials that are included show the same effect, that's reassuring. If there's variability and a couple trials show benefit, a couple trials show harm, we might lower for what we call inconsistency. Indirectness, we didn't really talk about, but if, let's say, we're trying to do a guideline in kids, we wanted to look at the effect of this immunomodulator on acute kidney injury in kids, But when we look through the literature, all of the data is in adults. In that case, we might lower for indirectness. There's important differences in the data that we found compared to the question that we're asking. Ideally, we would have found data in kids, but if there's no data in kids, we might still apply the data from adults, but lower for indirectness. Imprecision gets at the width of the confidence intervals and the number of events in patients, and then publication bias is fairly intuitive. And so we go through this exercise, again, per outcome, where we rate the certainty. How certain are we? Okay, this immunomodulator decreases acute kidney injury. We have moderate certainty after going through this exercise. This immunomodulator decreases mortality. When we go through this exercise, we have low certainty in the effect on mortality. And again, it's a step-by-step process. If I had longer, if I had an hour or an hour and a half with you this morning, I could more walk through step by step. And if you do a grade webinar, or if you do a grade workshop, that would be the idea, is to work through these for those on this call. And I know there are some of you that have been to a grade workshop. You work through this worksheet and we go into the intricacies of how we apply each of these. But again, the general concepts you've all done on this call. And I have no doubt that within a 4 or 6 hour workshop, you would all be grade experts for sure. There are a couple of tools out there for summarizing grade ratings. The guideline development tool is freely available. The website is there, and it's one of the tools that I often use. And what you can do is you can use it to produce what we call an evidence profile. This was one that we did looking at the effects of non-invasive ventilation in patients with COPD. And it's nice because it summarizes the evidence pooled across the included randomized control trials. And then it also shows right in the same table the certainty assessments and whether you made any downgrades for any of those domains that we just talked about. And here it shows that non-invasive ventilation has high certainty of decreasing mortality in patients with COPD exacerbation. This is the sort of evidence profile that we'll present to the guideline panel when we're looking at making recommendations. And so, in step 3, how do we make recommendations? So listen, I've walked you through coming up with the questions. I've walked you through summarizing the best evidence and rating the certainty in the evidence. But an important third step is going from the best evidence to coming up with the clinical recommendations themselves. And I alluded to this already, is that when we come up, maybe another misnomer about guidelines is, and evidence-based guidelines, is that they're only based on the evidence. And it's not true. Guidelines are not just based on the evidence. And maybe that's surprising to hear from somebody that's an evidence-based researcher. But it's crucial that the experts in the room provide input on not just the evidence, but around the certainty of the evidence, around the cost of interventions. Evidence could be great to support an intervention, but if it costs $1 million per patient and requires 20 people to operationalize, maybe it's not that possible or practical. ECMO jumps out as a great one. I've been a part of ECMO guidelines where, despite evidence of benefit, the implications of costs and resources factor in when it comes to recommendations. Patients' values and preferences. Patients have different values and preferences. Patients might not value an intervention that might save their lives if there's a potential that it might impact their quality of life in the long run. Feasibility, equity, these things factor in as well. And GRADE has this process called the evidence to decision process, where it guides panels through incorporating these different aspects. And, when I walk panels through developing recommendations, we'll usually book about a 2-hour Zoom call where we'll walk through this ETD process step by step, and we'll guide panels through it. And it guides you from going from the evidence to developing, sorry, I need a sip of coffee. Going from the evidence to developing recommendations themselves. And this is a figure that we had included in intensive care medicine editorial a number of years ago now, where it sort of shows the GRADE guideline machine that incorporates these different aspects, the balance between harms and benefits, resources and costs, patients' values and preferences, and outputs the options that come from GRADE guideline development, which are either a strong recommendation, and we use specific language to verbalize strong recommendations. We say, we recommend. We recommend means a strong recommendation. And it's meant to be like, strong recommendations are those that you make protocols out of. It's meant to apply to 95% of patients. There might be a couple of patients that strong recommendations don't apply to, but the vast majority of patients should follow the course of a strong recommendation. The other option is a conditional or weak recommendation. Those are actually synonymous. We used to call them weak recommendations, but especially translation to some languages, and I think Japanese, Chinese were ones where weak had very negative connotations. And so we moved from weak to conditional recommendations. And we use the words we suggest for conditional recommendations. And these are the situations where there's a better balance between the benefits and harms. And, it recognizes that the majority of patients would choose that course of action, but it might only be 60 or 70%. There still might be a large minority that would choose otherwise. And this is another one of the things that gets often confused is that folks are uncertain about how to apply a conditional recommendation. And there's meant to be a difference. Strong applies to everybody. Conditional recommendations are not meant to apply to everybody, but simply apply to a majority of patients that would be considered eligible for that PICO. So we talked about this a little bit already, and I'm happy to share these slides if folks are interested. The implications for patients, clinicians, policymakers of strong recommendations, just do it, versus conditional recommendations, which mean probably do it, but maybe think about it a little bit longer. Just to tie up, I'd say hopefully maybe you're looking at this being like, gosh, making guidelines isn't easy. And it's the truth. I don't know. I've never had a baby myself, but I think being a part of guideline development process, I've heard is like childbirth. It's painful and challenging at the time. At the end, you're really happy with the final product. And then you agree to participate in your next guideline, forgetting about how painful the last one was. And that's been my experience with guideline development to this time. But it's been a great opportunity often to get to engage with folks and get to be in the room with the experts in developing these recommendations. And this is just a small smattering of the guidelines that I've been able to be a part of, but certainly early in my career was a fantastic opportunity to get to participate with, driving the evidence and informing care worldwide. And so just to end with my last slide, which is maybe a few pearls for the guideline development process, doing guidelines is as much as working with people as it is the science. And I think it's so important to work with people you like. I'm at the point now in my career where I pretty much will only say yes to helping with a guideline if it's with folks that I like to work with, because well, maybe that's good life lesson outside of guidelines as well. Don't take on too much. I think that's really important, not taking on more PICOs than you can handle, given the work that's required. Prioritizing diversity and opinion and making sure that the panel is diverse and includes folks, as I said from before, with diverse interests, career stages, sex and gender. Talked already about guideline developments often as much about managing people, and agreeing to another guideline is forgetting about how hard the last one was. I appreciate the opportunity to present. Happy to open the floor if we have time to questions. Thanks again.
Just a quick question for you, Bram, as I was listening to your talk. We do know that sometimes we do have guidelines that make recommendations, and some of them may not be practical in a particular backyard, say, in a particular situation. And you may find that such guidelines either need to be modified to suit the needs, or, you may find that resource might be a big limiting factor to, apply certain guidelines. In such scenarios, how do you go about tweaking the guideline? Or would you create a separate guideline? Because to me, if you start making guidelines for each backyard, essentially, you'll end up with a pile of guidelines. And I understand that you said you shouldn't need global representation when we do guidelines, but clearly, this is always a tricky situation to handle. What would you suggest when it comes to, say, contrasting guidelines with bedside practice, especially when you're unable to follow the guideline?
Yeah, thanks, Kieran, for the fantastic question. And I think you're absolutely right. This is the biggest challenge with guideline development. And Surviving Sepsis tries to, for example, to take the perspective of being applicable to all. And we have tried to include folks from Global South, and we have a couple of folks whose input is supposed to be specifically designed. So, we might temper recommendations that might have been strong recommendations in high resource settings now are conditional because there's uncertainty about application in lower resource settings. But it is a huge challenge. And I guess what I'd say, like GRADE has come up with this process whereby you can use the same evidence summaries because the evidence summaries aren't going to change. You've done the systematic review, you've summarized across the RCTs, that's going to be applicable everywhere. It's those evidence to decision factors that will apply differently. And so they've come up with this adaptation process where one might say, let's say ARDS guidelines are published by the ATS tomorrow. Local folks, let's say in India or wherever, could use the evidence summaries, but then go through their own ETD process to sort of think through the specific resources, values and preferences, practicalities, feasibility, see if it applies differently, and might come up with slightly different guidance, but based on the same evidence summaries. It's a great process. It's not done as often as maybe it should be. And what ends up happening, as you say, is that folks look at doing their entirely new process in their different jurisdictions, and then it becomes a problem when recommendations are different. And I hear you, but yeah, maybe doing a better job of specifically looking at those adaptations and seeing if we can consider those separately. I think it's a win if at the very least, even some of these larger guidelines are putting in specific considerations about LMICs in Global South as well. And so I think it is like it's evolved to the point that surviving sepsis and ATS guidelines, and I think the fact that they even have some discussion about applicability to places where resources might vary, I think is also an important advancement. But it's a huge concern, and I hear you, and it's important to walk through.
Yeah, thank you. Prashant, you have something to say?
Yeah, thanks. Continuing what you started, I think that was the same thing which was coming in my mind, but I'm going to put it in a different perspective. Since Bram started with the diversity aspect, and I think it's a big challenge how to involve a panel which is really diverse. And that definition of diversity is also varies from the institution which is sponsoring itself, tries to bring down the diversity mainly to sex or to bit in geography where they are looking. But whether we really reach up to that diversity is a big challenge. So Bram, how as a methodologist you ensure that when we say diversity in a global guideline is really ensured? And that's number one. And if that is ensured, how does it, if you are not able to reach that part, or especially when your hands are bounded by the society, most of these guidelines are sponsored by some of the other societies. So in that case, what do you do to ensure that balance of representation?
Yeah, it's hard, Prashant. I'm not saying it's not. And as different societies feel more strongly about this than others. SCCM, for example, really tries to embrace, especially the multidisciplinarity. They always want to make sure you have nurses and RTs and this sort of stuff. Whereas, other societies, I know many of us engage, like some of the European Society of Intensive Care Medicine, like their guidelines are great, but probably maybe a little bit less in terms of diversity for some of these specialties. So you see variability that's already done. I think as a methodologist, to just do my best to push, and folks care about this. I think when you go to the journals and you try and publish an uptake, people now are paying attention to this, and if they're seeing that it's all, it was it the sepsis definitions in 2016 got a little bit of pushback because it was a high percentage of white men from high income countries that were on those the sepsis definitions. And so I think people are paying attention to this. And I think it only impacts positively when guideline panels do incorporate the diverse input. Prashant, the other problem is even if you have a diverse panel, when you're on the panel calls, it's often a select few that are very vocal and loud and sharing their opinions. And so I look upon that like as I've gained experience as a methodologist in leading those guideline development calls, also being very clear to make sure that everyone's voice is heard, and making sure that it's not the same folks that are voicing up, and those people that are maybe a little bit quieter have an opportunity to share their opinion as well. But again, super hard stuff. And then you bring in the society endorsement is a challenging piece to deal with because sometimes the society is keen to have their leaders on the guidelines as well, and negotiating that balance. But I think always just trying to frame back to we want these guidelines to be like uptaken and used and cited and incorporated. And I think that having the multidisciplinary piece will help with folks seeing that credibility and using those guidelines. But it's something that's continued to evolve. It's still evolving. I mean, look at even in the US, they've taken some steps backwards maybe on some of these things in the last little while. But I think it's something that we all just need to continue to push.
Interesting. Bram, I have a question from the audience. Amita Singh wants to ask, how can we ensure that global guidelines are adaptable for low to middle income countries where the gold standard resources might not be, might not be
Yeah.
available?
Yeah, no, it is. It is. We started this discussion a little bit already. I was involved with the WHO COVID guidelines, which was an enlightening experience because here were guidelines that we truly wanted to be applicable across the world. And we made sure those guideline discussions were fascinating. We'd often be at like 2 in the morning my time or 4 in the morning because we had folks from literally across the world and from different jurisdictions, Indonesia, the Philippines, Sub-Saharan Africa. And it was so interesting to go through because we were trying to have these guidelines that were applicable in Europe, but at the same time in different jurisdictions. And maybe one of the things that always jumped out to me was that how different these places are and availability is, but at the same time how similar they are too, and a lot of even low middle income countries during the pandemic would say, if there's an intervention that saves lives and is helpful, like IL-6 receptor blockers, it might be challenging for us to get, but we should be making guidelines that suggest for interventions that save lives. And maybe that provides a little bit of impetus or a little bit of push for administrators of different jurisdictions to push for funding and access to these interventions if they're supported by guidelines. So I'm not saying that there's not important LMIC considerations. There are, but I think when it comes to the guidelines themselves, maybe more similarities in the applicability of recommendations than we think and the benefits of providing recommendations for interventions that we know that work. But it's still, as discussed before, still a challenge. And so I think that even advancements of talking through these things and making sure that we acknowledge the fact that some of these expensive interventions aren't as available. At the same time, some interventions like we addressed as part of the corticosteroid guidelines with the SECM, things like dexamethasone for severe pneumonia or corticosteroids. These are cheap interventions that we think if we think save lives, we should be making, maybe more strong recommendations for interventions based on accessibility and costs. So, Amita, maybe not a perfect answer, but I think it's important to make sure that again, at least today we're discussing these things where I feel like again 20 years ago, 30 years ago, it wasn't even entering to the discussion.
Absolutely. Absolutely. One last question before we move to the next speaker, Bram. How to make hospital policies from existing guidelines? This is Dr. Santosh Kumar.
Yeah, this is also a challenge. Like strong recommendations translate really well into hospital policy and hospital protocols because strong recommendations are meant to apply to everybody. So that's much more straightforward. If we make the challenge is applying conditional recommendations because conditional recommendations are meant to say, the majority of people would maybe a conditional recommendation to delay a renal replacement therapy initiation for a patient with acute kidney injury until they have an absolute indication. That makes sense, but there's going to be a proportion of patients that you're going to want to start aggressively, maybe those with profound metabolic derangements or maybe those with intoxication or whatever it might be. And it's really hard to encapsulate conditional recommendations into hospital policy and guidance. And I've struggled with that as well. Listen, like I can't pretend to be a knowledge translation expert when it comes to guidelines. I do think I bring some expertise when it comes to guideline development, but then, translation of guidelines into decision aids, into hospital policy, it's a whole nother science in itself and an important science because we can make great guidelines, but if they're not translated into practice, then they're not going to be as effective. But that is a struggle, Santosh, is looking at conditional recommendations and seeing how to translate them. But there's been some great decision aids that folks have made. The Magic Group in Scandinavia, McMaster, they've worked at a ton of, look, this is a conditional recommendation. If you use it out of 100 patients, 20 more would survive, but there are these important side effects or other considerations. And so I think that's probably the best way to look at knowledge translation of guidelines is into, EMR-based decision aids that can be used and in combination with patients and their loved ones in guiding decisions rather than hospital policy.
Thank you. Tapas, you want to say something?
Yeah. Just maybe taking the last statement by you, Professor Bram, excellent talk. I would be coming to the nephrocritical care. So many guideline recommendations, particularly in nephrocritical care, are based on low or very low certainty evidence. We all know. Now, the question is, maybe I would say $1 million question. As clinician at the bedside, if tomorrow I will be just going to the bedside, how should we responsibly act when guideline strength conflicts with the physiologic reasoning, or I would say the patient heterogeneity? Now, how I should be expected to do at the bedside? What decision I should make? Like
Yeah.
the guideline or my own decision based on what I personally feel from the physiology perspective.
I get it's a great question. I guess a couple of things. Guidelines are just meant to be guidelines, right? They're meant to apply to the majority of patients, but there's always going to be exceptions. And so I think guidelines are meant to be guidelines. I think especially conditional recommendations, TAPIS, should just be, the majority of patients, but you might have a good reason. You're the expert at the bedside that's telling you that this isn't the best thing to apply, and that's okay. The other thing I guess I would say is that we have lots of examples in critical care and nephrocritical care where something makes sense physiologically, but then when we test it in an evidence-based manner in RCTs, it doesn't make sense, right? Tight glucose control, large tidal volumes, vitamin C replacement, vitamin D replacement, like there's growth hormone replacement. There's a laundry list of early dialysis. There's a laundry list of things that, make sense physiologically to us, but when we went to test them in RCTs, it doesn't translate. So I would say, you're the expert, do what makes sense at the bedside based on patient heterogeneity and patient characteristics, but incorporating best evidence and RCT data and that goes into the guidelines crucial as well. And then the last maybe thing I'll say, and then I'll stop, is that I think that a lot of the guidelines, like they are applicable to the strong academic physicians like yourself that are practicing at the bedside, but probably the group that's most guidelines are applicable to is, folks working out in the community that don't have the best evidence at their fingertips, that can't go through the exercise of, summarizing all the best RCTs urgently. And they rely so much on these guidelines to help guide their care. And so, especially for those that aren't as up on the literature, the guidelines can provide a nice, clear pathway to this is the summary and this is what the experts incorporating the best evidence would suggest to practice with.